Okay, for this session, we're going to be talking about hyponatremia. Here are the learning objectives for this session. We'll talk about the pathophysiology of hyponatremia and develop an approach to diagnosing and managing the different types of hyponatremia, including hyponatremia emergencies. So hyponatremia is defined by a serum sodium less than 135 milliequivalents per liter, and it is very common. It's the most common electrolyte disorder. It's about 5% of all adults at any given time probably have hyponatremia. When you look at hospitalized patients, it's about a third. And then if you look at specific types of patients, patients with heart failure, patients with cancer or liver disease, rates are pretty high. So hyponatremia does not mean you have low sodium in the body. So this gets confusing, especially when you're trying to explain it to patients. Just because the serum sodium level is low does not mean they have low sodium in the body, because your sodium is a concentration. And so really what low sodium in the blood means is that you have an excess water relative to sodium in the extracellular fluid. So really hyponatremia is a water problem, not a sodium problem. Reminder that sodium, glucose, and urea are the major osmoles in the extracellular fluid. So if you want to calculate your estimated osmolality, you would use those three values to do that. Sodium and glucose are the osmoles that determine tonicity. Urea can cross cell membranes, and so it doesn't contribute to tonicity. Really just sodium and glucose are the main factors there. And if your sodium gets low, your sodium concentration gets low, and your glucose remains normal, then you can see why your overall tonicity will drop. And this is where it becomes a problem, because if the tonicity is low in the extracellular compartment, then water will move into the intracellular compartment to equilibrate, and that can cause edema in those cells, including in your neurons and in your brain. So cerebral edema is the main complication of hyponatremia that we worry about. All right, let's talk about normal water homeostasis. So you have osmoreceptors in the hypothalamus whose job it is to detect changes in tonicity. So if the tonicity goes up, we need more water. So the posterior pituitary is going to release vasopressin, also called antidiuretic hormone, which is going to help you reabsorb water in the kidneys. And those hypothalamic neurons are also going to stimulate thirst, so that the person goes over to the sink and gets a drink of water. So ADH is going to bind to vasopressin 2 receptors in the collecting duct, and that's going to lead to insertion of your aquaporin channels in the collecting duct, and water is going to move then from the tubular fluid into the tubular cells and then into the interstitium, where they can be reabsorbed by the peritubular capillaries. And so the urine will become more concentrated when there's ADH there. And so that is going to increase your urine osmolality as the urine gets more concentrated. So tonicity is the main stimulus of vasopressin release, but there's other non-osmotic stimuli of vasopressin, including angiotensin II. So if you have activation of RAS, because you have low perfusion to the kidneys, that angiotensin II is going to stimulate the release of vasopressin. But there's other non-osmotic stimuli of vasopressin that become pretty important clinically. Nausea and pain are very common things that we see in the hospital that can stimulate vasopressin release. Also extreme exercise, postoperative state, and lots of medications. So here's a nice graphic that's just showing that the osmoreceptors in the hypothalamus will detect those changes in tonicity, and then those will signal to the posterior pituitary to release vasopressin, which can then go and act on its target tissues, including the kidneys, where it can increase water absorption. The other big thing that stimulates ADH is if you have activation of RAS. So if the kidneys detect a drop in renal perfusion, they'll secrete renin, which converts angiotensinogen to angiotensin 1, which is then converted to angiotensin 2, which stimulates the posterior pituitary gland to release ADH. So those are your main drivers of ADH. It's going to be increase in tonicity or angiotensin 2 levels. Here is a beautiful illustration of the collecting duct by Dr. David Morton that shows us that we see both the activity of ADH and aldosterone here. So ADH is our purple molecule that comes through the peritubular capillaries and can then move into the interstitium where it can bind to ADH receptors on the collecting duct. That's a G protein coupled receptor, so there's going to be a series of secondary messengers that lead to aquaporin being inserted on the tubular side or the apical side of that collecting duct so that water can then travel into the collecting duct through another aquaporin, which is always present on the basolateral side, and then that water can be absorbed. You also see the activity of aldosterone, which can diffuse into the cell, bind to mineralocorticoid receptors, upregulate production of ENaC, which is going to reabsorb sodium from the tubular fluid. So one of the main things I want you to remember from that is if urine osmolality is high, it's because the urine is becoming more concentrated. That's because ADH is high, right? So anytime you have ADH turned on, you're going to have aquaporins turned on, and that's going to bring water out of the tubular fluid and raise the urine concentration, the urine osmolality. So urine osmolality is a surrogate for ADH. If you see that the urine osm is high, you know that ADH is high. So here's a nice diagram from a JAMA Review article from 2022 that shows how we kind of break down the pathogenesis of different types of hyponatremia, specifically hypotonic hyponatremia. But all of them ultimately involve excess ADH or excess vasopressin levels, whatever the trigger, and that's going to lead to increased water retention, which is going to dilute serum sodium, and that's what causes most hyponatremia. So what are your symptoms of hyponatremia? Well, you're mostly going to see symptoms in folks with acute hyponatremia because their brain hasn't had time to adapt to the fluid shifts. People with chronic hyponatremia usually don't have much symptoms because their brain will actually adapt to correct that brain swelling over about 48 hours. So if they've had hyponatremia longer than 48 hours, they might not have any symptoms. But for acute hyponatremia, the main symptoms you're going to see are weakness, nausea, vomiting, headache, confusion, and then really severe symptoms would be like seizures, which you're usually going to see if the sodium is less than 110, or cardiorespiratory arrest resulting from brain herniation. One reason we care about the chronicity of hyponatremia is that if you've had it for a while and your brain has adapted to that swelling by getting rid of other osmolytes in those neuron cells, then if you rapidly correct the sodium in someone with chronic hyponatremia, it can actually injure the neurons, specifically in the central pons, in a process called myelinolysis, and that can lead to very severe neurologic problems, including hyperreflexia, pseudobulbar palsy, Parkinsonism, locked-in syndrome, quadriparesis, and even death. And that can happen, a day after the rapid correction. It can happen a week after, and you may not see anything on brain imaging for up to a month after the insult. So this is one reason we worry about whether it's acute or chronic hyponatremia. The risk factors for osmotic demyelination include severe chronic hyponatremia, so patients with a sodium less than 110 are the highest risk. Folks with alcohol use disorder, liver disease, hypokalemia, and malnutrition. So these have all been identified as major risk factors for osmotic demyelination, which is a rare complication, but if you have patients with these risk factors, you should be extra careful with them. And really the only thing that we have to try to prevent this is to correct as slowly as possible. And the data is pretty mixed out there whether this actually makes a difference, because you can have a patient where you correct them very slowly and they still develop osmotic demyelination. But it's really the only thing that we have is to just try to correct very slowly so that the brain has time to adapt to the new fluid status. So our goal is to try to not correct their sodium more than 6 milliequivalents per liter per day, which can be very challenging to go that slowly. All right, so now let's talk about how we classify hyponatremia. We usually break it down into hypotonic hyponatremia and hypertonic hyponatremia. There's also something called isotonic hyponatremia, but it's really not clinically relevant usually, so I'm just going to skip that. Hypotonic hyponatremia is by far your most common clinically meaningful hyponatremia, and we'll break those down further into volume status. So hypovolemic, low volume status, hypervolemic, too much volume, and then our euvolemic, which is our normal volume folks. And then we can kind of categorize different types of hyponatremia based on that volume status. Hypertonic hyponatremia is kind of a special case, usually caused by hyperglycemia that we'll talk about in a second. So hypovolemic hyponatremia is going to result from a loss of sodium and water, but more sodium than water. And so anything that causes hypovolemia can lead to a reduced effective arterial blood volume, sometimes called effective circulating blood volume. And the kidneys are going to sense that as a reduction in perfusion, and they're going to release renin, which can then increase aldosterone production, which will help you hold on to urine sodium to try to correct that volume problem. But you're also going to stimulate the release of ADH, which will lead to the retention of water. And as we talked about before, if we increase ADH levels, we're going to concentrate that urine and make our urine osm higher. And if we retain more water than sodium, then the patient will become hyponatremic. And so that could happen especially in patients who are hypovolemic, who maybe are drinking a lot of water, and their ADH is going to hold on to that water, maybe more than sodium. Those patients can become hyponatremia, and they will have a low serum osmolality if you measure it. But you don't usually need to check labs in hypovolemic hyponatremia because the clinical picture can generally tell you what's going on. So, people with GI losses like vomiting, diarrhea, people with bleeding are going to have a low effective arterial blood volume, so that can activate RAS and lead to water retention. Excessive sweating, so normal amounts of sweating, you're actually losing more water than salt. So you would expect sweating to actually cause hypernatremia. But if you are doing like extreme sports like marathons and things like that, excessive sweating, you can actually lose so much sodium. And then if you couple that with drinking a lot of water, that can lead to hyponatremia. Third spacing is an important thing that we see, especially in the hospital when patients come in with very inflamed conditions like pancreatitis or massive trauma or serious burns, where everything becomes leaky and fluid moves from the intravascular space to the interstitial space. And that can be in the peritoneum or in the pleural space or wherever. We call those third spaces. And that can lead to a drop in effective arterial blood volume. Activation of RAS, too much ADH can lead to hyponatremia. And then the other big category is your renal losses. And in these folks, if you measure their urine sodium, it's going to be high because they're losing sodium through their urine. That's going to be from diuretics. It can be from salt wasting disorders. But I would say most clinically common are going to be probably diuretics. So management of hypovolemic hyponatremia is really easy. You just have to restore their normal volume status so that it will shut RAS off and ADH will stop absorbing water. And so we do that by giving isotonic fluids like normal saline or lactated ringers. You could also give them blood transfusion if they're hemorrhaging. And in a patient who's like clinically not that sick, you can also just rehydrate them orally. Just make sure that whatever you're giving them has sodium in it. Hypervolemic hyponatremia is when you have too much water and sodium, but more water than sodium. And these are usually clinical problems where they have a sodium retention problem, but if they're holding on to too much water with that, it can result in hyponatremia. And so this, just like hypovolemic hyponatremia, this is caused by a reduction in effective arterial blood volume with activation of RAS, aldosterone, and ADH. You would expect urine sodium to be low in these patients because aldosterone is on, but a lot of them are receiving diuretics, so you have to be aware of that when you're checking those levels. And then you'd expect the urine osm to be high because ADH is turned on. And so in these patients, if more water is retained than sodium, they're going to be hyponatremic. And it's not every patient with hypervolemia develops hyponatremia, right? Maybe 30% of patients with heart failure. But if you do see hyponatremia, this is the pathogenesis. So we talk about congestive heart failure is a very common cause of this, especially if they have HFrEF, so reduced ejection fraction. That's going to lead to some pump failure. They're not going to get enough blood flow to the kidneys, and they're going to get activation of RAS. Cirrhosis can also lead to inadequate perfusion of the kidneys with activation of RAS, and so can nephrotic syndrome because you have low oncotic pressure that leads to the loss of fluid from the intravascular compartment to the interstitium. That's going to decrease your effective arterial blood volume and activate RAS. Kidney failure is a special case of hypervolemic hyponatremia where it's not so much about the effective arterial blood volume, it's more the reduction in GFR and the inability to excrete water. And so those folks will retain water just because their GFR is low, and that can lead to dilution of their sodium, and they're going to be hypervolemic on exam. So the management of hypervolemic hyponatremia is also usually pretty straightforward. Your goal is just to get rid of excess water. So you can do that with diuretics. You can restrict their fluid intake, which is not very nice, but sometimes we have to do it, especially in folks with really low sodium, like cirrhosis patients. Sometimes we have to just cut their water, intake down to like a liter a day. And then, if they have really poor kidney function, you might have to do dialysis to remove that excess water. All right, the next case of hyponatremia that we see very commonly is syndrome of inappropriate ADH. And so we talked about how normally ADH is only released in response to high tonicity or if RAS is activated. If there's anything else that leads to ADH secretion, independent of that, we would call that inappropriate. And in those patients, your urine osm is going to be elevated because ADH is high, right? They are concentrating their urine because they have ADH turned on, urine osm will go up. But because RAS is not turned on in these patients, their urine sodium will normally be over 30. They are not holding on to sodium from tubular fluid. So they're just going to be urinating out sodium like normal. So syndrome of inappropriate ADH secretion is very common in the hospital because there's all these non-osmotic stimuli of vasopressin, nausea, pain, and postoperative state. Very common. So if you see a patient after surgery with hyponatremia, this is it could be hypovolemia, right, because they were fasting all day for surgery or whatever. They lost a lot of blood in surgery. Or it could be syndrome of inappropriate ADH because they're in severe pain or they're really nauseated or whatever. There's a lot of medications that can cause this, so especially your chronic hyponatremic patients, if you diagnose them with SIDH, you're going to be looking at their medications to see if those are contributing. Malignancy is the classic one, right? Your small cell lung cancer can cause SIDH, but there's other cancers that can trigger ADH secretion as well. Pulmonary diseases, I don't know if we know why pulmonary diseases can trigger SIDH, but like pneumonia, asthma, COPD, cystic fibrosis, all of those things can trigger more ADH release from the posterior pituitary. And then our central nervous system diseases like brain tumors, brain abscess, brain bleeding, trauma, hydrocephalus, those things can also stimulate the pituitary to release more ADH. Whenever you're working up someone for syndrome of inappropriate ADH, you want to rule out adrenal insufficiency and hypothyroidism because those can also stimulate the pituitary, and those would have a different treatment. So for management of syndrome of inappropriate ADH, the main thing you want to do is treat the underlying disorder. So if it's a lung cancer, treat the lung cancer. If it's a medication, stop the medication. To actually make the sodium number go up, usually you're going to have to fluid restrict these folks because all that ADH is going to make them hold on to whatever water they drink. So you have to restrict them down to like a liter and a half of water per day, sometimes more. If that doesn't work, then we can add on sodium chloride tablets, or we can add diuretics to help them get rid of more water. You can also use urea therapy because that will help them excrete more water. Medications like Vaptans will actually block your ADH receptors, and so that can turn off your ADH. It's pretty expensive treatment. They can cause liver dysfunction, and it can cause very rapid correction of your sodium. So we rarely use Vaptans in this case, but you could. And then for really stubborn cases where the sodium is just not coming up after multiple days of fluid restriction and these other conservative treatments, you can give hypertonic saline to force the sodium up. You just have to monitor them very closely. The important thing I want to say about SIADH is that you should not give them isotonic saline. So normal saline can actually cause your sodium to go down in SIADH, and that's because the concentration of normal saline is 308 milliequivalents per liter. So if that patient has a lot of ADH, their urine osm is already going to be high, maybe 600 milliosms per kilogram. And if you give them a liter of normal saline, they can excrete all of that sodium chloride in just 500 mLs of urine, and then they will just hold on to that other 500 milliliters of water, and their sodium will go down further. So this is something we see all the time. A patient comes into the emergency room, they have hyponatremia, someone gives them a liter of fluid, and then when we recheck their sodium, it has actually gone down lower. That's usually a pretty good clue that the underlying cause is SIADH. Primary polydipsia is a less common but important cause of hyponatremia, and this is just people who are drinking way too much water. And it's not like, your people who are just drinking like, 6 Diet Cokes a day. This is people who are drinking over 8 liters of water a day. Usually they have an underlying psychiatric disease, so we sometimes call this psychogenic polydipsia. And in these folks, their kidneys are fine. RAS is not activated. And so if you just don't let them drink water, their kidneys will rapidly get rid of the water. You will make maximally dilute urine. So if you check this person's labs, they're going to have a very low urine osm because their kidneys are doing what they're supposed to. They're getting rid of water. You're going to have very dilute urine. Low solute intake is a very important type of hyponatremia that you should be aware of. This is caused when the patient has inadequate sodium and protein intake, and often that's coupled with hypotonic fluid intake. So your classic example is beer potomania. So if someone is just drinking beer all day and not really eating anything, beer is hypotonic as well. They can really drive their sodium down. Or you got a little old lady who just eats like toast, which has, maybe some Wonder Bread, which has like no protein, very little nutrition, and then they're drinking tea. So you need like a certain amount of solute every day just to get rid of water. So if your normal daily solute is about like 600 milliosms per day, and your normal fluid intake is like 2 liters a day, then you can get rid of those 2 liters of urine, and the concentration will be about 300 milliosms. Versus if your solute intake is super low, because all you're doing is drinking beer, maybe it's 150 milliosms a day, and your maximally dilute urine is 50 milliosms per liter, then the maximum amount that person can excrete is 3 liters a day. So if they drink more than 3 liters a day, they'll just hold on to all the excess water and their sodium will drop. So if you're working these folks up, their urine osm is going to be low, just because they don't have any urine osms, right? They don't have urea because they're not eating protein, and they don't have sodium because they're not eating enough solute. So they're going to have low urine osm. Their urine sodium will be low for the same reason. And so the way you treat this is just by feeding them. You just get them to improve their nutrition, especially protein intake. That protein can be broken down to urea, an important urine osmol, and then they'll get rid of that free water. So really these folks just have inadequate free water diuresis because they don't have enough osmoles to get rid of water. You really want to avoid isotonic fluids in these folks because they don't need very much solute to start excreting free water, and you could actually trigger a very brisk diuresis and rapidly correct their serum sodium if you give them IV fluids. And like we talked about before, these are your patients with the highest risk of osmotic demyelination syndrome because they usually have chronic hyponatremia. Maybe alcoholism is a player, and they're malnourished, and those are all big risk factors for osmotic demyelination syndrome. So to be honest, these are the patients that terrify me the most. You get the patient that comes into the ER, someone gives them a liter of fluid before they think about it, and suddenly their sodium is just shooting up really quickly because they can get rid of all of that excess water they've been holding on to. Hypertonic hyponatremia is our last kind of special case. So we talked about how sodium and glucose both help determine tonicity, right? And so if you have an increase in serum tonicity, that's in the ECF, you're going to pull water from the ICF. So hyperglycemia is your most common cause of this, but you can see it with other hyperosmolar things like contrast media or mannitol, which is a type of osmotic diuretic. If serum glucose is high, then your serum tonicity will increase, and that's going to suck water into the ECF, which will dilute your serum sodium. So when you see someone with really high blood sugars and low serum sodium, you can try to estimate what their true sodium concentration should be by adding 1.7 for every 100 milligrams of glucose above 100. When you check serum osmolality in these folks, it's going to be high. I usually don't bother because if I see that their glucose is over 500, I already kind of know what's going on. And really the treatment for this is just to fix the hyperglycemia. They usually, or most hyperglycemic patients are a little bit hypovolemic as well, so I will usually give them some fluids. But just treating the blood sugars should normalize the sodium. So when you're evaluating a patient with hyponatremia, the first thing you want to do is identify if they're having severe symptoms like seizures, so you can start emergent treatment. If that's not going on and they're just like chronic hyponatremia patient without symptoms, do a history and physical exam and try to figure out if there's a specific etiology that could be causing this. You want to do a good volume status exam so that you can categorize this person. Are they hypovolemic, euvolemic, or hypervolemic? If you're going to check labs, urinosum is probably your most useful one because if the urinosum is high, you know that ADH is active, and then you have to figure out clinically if that's appropriate or inappropriate. In the hypovolemic patient, that's totally appropriate for your RAS to be turned on and your ADH to be active. In your patient with congestive heart failure or cirrhosis, it's expected. I don't know if I'd call it appropriate, but you expect RAS to be turned on. In your patient with SIDH, though, where they're euvolemic and there's really no reason for ADH to be turned on, we call that inappropriate. If the urinosum is less than 100, it means that ADH is off, like in patients with polydipsia, or it means that they're so malnourished they don't have any urinosums to begin with. You can also check urine sodium, which can help tell you if aldosterone is turned on, but it's also going to be low in people with polydipsia and low solute intake, and it's going to be elevated if they have like renal losses. Where I think urine sodium is the most useful is in patients where you suspect SIADH and you want to confirm that their ADH is turned on and their aldosterone is turned off. So if they have a high urinosum and a high urine sodium, that's pretty consistent with SIADH. So this is just a chart from that JAMA review article. Again, that's just kind of showing you we can do our history and physical, and then we will categorize patients based on hypovolemic, euvolemic, and hypervolemic, and then check these labs to help kind of guide what we think the most likely cause is. No matter the cause, our goal for sodium correction is usually no more than 6 to 8 milliequivalents per liter in 24 hours. So if you're doing a treatment and their sodium goes up faster than that, what you can do is give dextrose 5 in water, or 5% dextrose in water, we call D5W, and you can give desmopressin, right, our synthetic ADH analog, to help hold on to water to bring their sodium back down. So if you overcorrect someone, you do usually have time to bring their sodium level back down by basically just adding a bunch of water to the system. And if you have a really high-risk patient, you can just give them desmopressin kind of prophylactically. If you have a patient who's having seizures, severe confusion, or cardiorespiratory distress, which could be a sign of an impending herniation, you want to correct them as rapidly as you can so you kind of accept that risk of osmotic demyelination because they might die in front of you right now. You're going to try to correct them by 4 to 6 milliequivalents over a couple hours. And the way we do that is with hypertonic saline. So usually 3% sodium chloride, and you just give boluses over 10 to 20 minutes. You're going to check their sodium level after each bolus, and you're going to do it until you're at that target 4 to 6 milliequivalents in 1 to 2 hours. But really, you're only going to do that if they have really severe symptoms like seizures, confusion, or cardiorespiratory distress. All right, we made it to the end. Hopefully this was a helpful review of hyponatremia, something that you're going to see a lot in your clinical years.
and something that it's pretty important to be able to diagnose and manage. Thank you for your attention.